1. Rural health funding. Will $50 billion be enough? 2. What to make of the $50 billion Rural Hospital Grants Program? 3. $50 billion Rural Health Program. Hope or skepticism? 1. Rural health funding. Will $50 billion be enough? The uncertainty surrounding whether the $50 billion allocated by Trump for rural health care will suffice is palpable. Lincoln, Neb, KOLN, in a bid to address concerns over the significant cuts to federal health care spending, which President Donald Trump enacted on Independence Day, Congress has earmarked $50 billion for rural hospitals and medical providers. However, the pressing question remains: is this financial aid substantial enough to rescue the beleaguered rural hospitals? Alan Morgan, the CEO of the National Rural Health Association, a non-profit organization focused on rural health policy, expressed his doubts, stating, "I have more questions than I have answers. No one has those answers yet." Morgan pointed out that the new funding, intended to be utilized over a 5-year period, pales in comparison to the staggering $155 billion in projected cuts to rural Medicaid spending over the next decade, as estimated by KFF, the nonprofit health policy and research organization. There is a growing concern among experts, hospital administrators, and lawmakers from both political parties that Trump's legislation could severely impact rural hospitals and clinics, which serve a disproportionately high number of patients covered by Medicaid, the federal state health insurance program for low-income individuals. The new law proposes to cut over $1 trillion from Medicaid over the next 10 years, a move aimed at financing tax reductions that primarily benefit wealthier individuals. The introduction of the $50 billion fund was a strategic maneuver by Republican leaders in Congress to secure the support of party members who were initially hesitant to endorse such drastic cuts to Medicaid and other health services. In the Senate, this rural health initiative played a crucial role in garnering votes, including that of Alaska's moderate Republican Senator Lisa Murkowski, who voiced her concerns regarding the law's potential repercussions on health care in her state, where approximately 1 in 3 residents rely on Medicaid for their health coverage. Jared Cosin, the president and CEO of the Alaska Hospital and Healthcare Association, expressed his deep frustration with the law's drastic reduction in Medicaid funding, which he believes will have long-lasting negative effects on Alaskans. He criticized the Republicans for avoiding meaningful solutions by merely injecting funds into a program. "It's frustrating in the public realm when decisions like this are made fast and, frankly, carelessly," he remarked. "The consequences are going to fall on us, not them." The cuts to rural funding are particularly concentrated in 12 states, with significant rural populations, that expanded Medicaid under the Affordable Care Act. These states include Illinois, Kentucky, Louisiana, Michigan, Minnesota, Missouri, New York, North Carolina, Ohio, Oklahoma, Pennsylvania, and Virginia. Some Republican lawmakers have celebrated the $50 billion Rural Health Fund as a significant achievement in health care policy. However, there remains considerable uncertainty regarding which hospitals, clinics, and providers will benefit from this funding and the extent of the financial support they will receive. How the funding works ***. The Rural Health Transformation Program is set to distribute $10 billion annually from fiscal years 2026 through 2030. States are required to submit applications for their share of the funding by the end of this year, detailing how they plan to utilize the resources. The law specifies several potential uses for the funds, as outlined in an analysis by the Bipartisan Policy Center. Providing financial support to rural hospitals to sustain essential services, including emergency care and maternity services. Recruiting and training healthcare professionals such as doctors and nurses in rural areas. Enhancing emergency medical services, including ambulances and EMTs. Implementing new technologies, such as telehealth services. Offering treatment for opioid use disorders and mental health services. improving preventive care, and managing chronic diseases. Each year, half of the $10 billion will be evenly distributed among states that have submitted applications, while the remaining funds will be allocated at the discretion of the administrator of the Federal Centers for Medicare and Medicaid Services, currently Dr. Mehmet Ounce, based on factors like rural population and health facilities. While this program does not fully compensate for the anticipated losses states will face, Morgan views it as an opportunity to rethink rural health care funding. He advocates for states to have flexibility in utilizing these funds, emphasizing the importance of focusing on preventive care to maintain the health of rural communities while ensuring hospitals remain operational. If done correctly, it could really change the future course for rural America, Morgan stated, though he acknowledged the challenges involved. ***, the states most affected ***. Kentucky is projected to suffer the most significant impact from the new law's cuts to rural Medicaid funding, with an estimated loss of $12 billion over the next decade, according to KFF analysis. Kendra Steele, a spokesperson for the Kentucky Cabinet for Health and Family Services, indicated that the state's Medicaid department is awaiting further federal guidance to understand the implications of the new legislation. Over 1.4 million Kentuckians rely on Medicaid, including half of all children in our state, seniors, and other vulnerable populations, and the passage of this federal legislation will have serious consequences for these individuals, rural health care, hospitals, and local economies, she stated. Despite the introduction of the new program, states nationwide will need to reassess their budgets in light of the impending cuts, according to Hemite Warson, Executive Director of the National Academy for State Health Policy, a nonpartisan organization that assists states in developing health care policies. Every region is slightly different, and there's not a one-size-fits-all approach, she explained. Hospital ownership varies, as do the types of services that are critical for the communities they serve. They must explore innovative ways to deliver these services amid dwindling resources. Currently, approximately 44% of rural hospitals are operating at a loss, a higher percentage than the 35% of urban hospitals, according to KFF analysis of RAND hospital data. ***Rural at heart ***. Before the bill's passage, Ounce sought to reassure U.S. House Republicans that even districts not classified as rural could still access funds from the program. Pennsylvania Republican U.S. Representative Rob Bresnahan stated that funding could begin flowing to his district as early as next year, having met with Trump, Ounce, and others to secure commitments that hospitals in his area would be eligible for the funds. His district encompasses both suburban and rural regions, including the cities of Scranton and Wilkes-Barre. Although the legislation provides guidelines for determining which facilities or areas qualify as rural, Morgan anticipates a rush among lawmakers and providers to claim rural status to secure funding. "That's going to be a huge issue, defining who's rural," he remarked. "We're all rural at heart when it comes to money." For further inquiries, State Line reporter Anna Claire Vollers can be reached at vollers@stateline.org. 2. What to make of the $50 billion Rural Hospital Grants Program? Can a $50 billion lifeline for rural hospitals save them, or just politically protect them? Here's the deal. When Congress threw $50 billion at rural hospitals as part of a major tax and spending overhaul, it wasn't just about healthcare. It was a calculated move to soften backlash from Republican senators who feared the fallout of Medicaid cuts. But here's where it gets tricky. Will this cash infusion actually rescue struggling rural hospitals? Or will it become a political tool to placate communities while deeper financial cracks widen? Let's break it down. Back in the 1970s, when I worked on Medicaid initiatives for the Healthcare Financing Administration, now CMS, I saw firsthand how federal aid can blur the line between noble intent and political calculus. During the Carter administration, we launched a program to save urban safety net hospitals drowning in debt from caring for the uninsured. The goal was to expand Medicaid coverage and shift care from emergency rooms to primary clinics, supposedly lowering costs. But the real game was keeping these vital institutions afloat and keeping powerful allies happy. The program survived only until the Reagan transition, when the incoming team axed most funding. Fast forward to today, and history feels eerily similar. The new $50 billion Rural Hospital Fund is framed as a response to looming Medicaid cuts that could slash $155 billion in federal funding for rural areas over a decade. But here's the rub: most of the grants will be handed out before the cuts hit. That means hospitals will likely use the money for one-time fixes, like building renovations or temporary staff hires, rather than long-term solutions. Imagine a hospital hiring a dozen nurses with grant funds, only to face layoffs when Medicaid payments drop. Not exactly a sustainable fix. The program splits the money into two pots. First, $25 billion will be distributed equally to states regardless of how many rural hospitals they have, creating a sort of rural health lottery. Second, another $25 billion targets initiatives like chronic disease prevention, or right-sizing healthcare systems, a term that often masks politically charged decisions to reduce services in small communities. Sound familiar? This echoes the 1970s National Health Planning Act, which aimed to rationalize the system, but collapsed under local resistance. Now, states face similar challenges. Will they prioritize long-term health gains or short-term political wins? And here's the part most people miss: the grants aren't limited to hospitals. State health departments, counties, and even community groups could get a slice, diluting the impact on the very facilities Congress claims to help. Add in potential Democratic oversight if they regain the House, and the program's future becomes even murkier. Senator Josh Hawley's push to double the fund to $100 billion over a decade highlights the gap between the $50 billion promise and the actual need. Is this a genuine attempt to fix a broken system, or just a stopgap to appease rural voters ahead of the next election? The bottom line: with $50 billion, you'll see plenty of ribbon-cutting ceremonies and feel-good stories about rural healthcare. But if Medicaid cuts proceed as planned, and the uninsured population grows, the real test will be whether this money cushions the blow, or just delays the inevitable. And that's the question we should all be asking. Can a program born from political compromise truly save the heart of America's healthcare system? Or will it become another cautionary tale of good intentions gone awry? Share your thoughts in the comments. Do you think this is a lifeline, or a political band-aid? 3. $50 billion Rural Health Program, Hope or Skepticism? Imagine a staggering $50 billion rural health initiative suddenly being added to a major tax and spending legislative package. It's a development that raises eyebrows and ignites curiosity across the nation. This last-minute addition to President Donald Trump's far-reaching tax and spending law has left health care leaders in hospitals and clinics feeling a mixture of optimism and uncertainty. The newly introduced Rural Health Transformation Program proposes that federal agencies distribute $10 billion annually to states over a span of 5 years, starting from the fiscal year 2026. However, as Sarah Homan, leader of government affairs at the National Association of Rural Health Clinics, emphasizes, the devil's in the details. The challenge lies in the actual execution of this ambitious plan. Homan represents over 5,600 rural health clinics and expresses cautious hope, stating, "An investment of this magnitude, focused on rural areas, which we have long advocated for, could truly transform healthcare in these communities." The challenges facing rural residents are daunting. They tend to suffer from a higher incidence of chronic diseases, experience shorter lifespans, and earn lower incomes compared to their urban counterparts. These intertwined issues have ravaged the financial stability of rural health systems, leading to closures of hospitals and significant reductions in essential services, such as mental health care and maternity care. In fact, approximately 1/4 of individuals living in rural America rely on Medicaid, the federal state program designed for low-income and disabled individuals. As Senate Republicans engaged in heated discussions about potential cuts to Medicaid spending, the introduction of this $50 billion initiative served as a strategic effort to alleviate dissent. Still, health experts and advocates remain skeptical, believing this funding may not suffice to counteract the anticipated losses in federal support. Leading the charge in support of this budgetary measure was Senate Majority Leader John Thune, a Republican representing South Dakota, a state with one of the highest percentages of rural inhabitants in the U.S. His website emphasizes efforts to bolster healthcare access in rural communities. However, his office did not provide an official response to inquiries regarding the specifics of the rural health program included in the bill. Similarly, Senator Susan Collins, a Republican from Maine who initially proposed the amendment for this rural healthcare initiative, also chose not to comment. On July 15, Senator Josh Hawley of Missouri introduced legislation aimed at reversing future Medicaid cuts, while also seeking to enhance funding for rural health services. Michael Cannon, a health policy specialist at the Cato Institute, a libertarian think tank located in Washington, D.C., remarks that this funding may have been allocated due to political maneuvering rather than genuine concern for rural health needs. He states, as long as the allocation of these funds is dictated by politics rather than actual patient need, we risk a misalignment between where the financing goes and what consumers truly require. According to estimations from the nonpartisan Congressional Budget Office, federal Medicaid expenditure is projected to decline by a staggering $1 trillion over the upcoming decade. This is a striking number, one that translates to real people potentially losing access to essential healthcare services. Frederick Blavin, a senior fellow and researcher from the Urban Institute, underscores this concern, noting, "These monetary figures represent actual individuals who may face severe consequences. Most states have broadened their Medicaid programs to accommodate more low-income adults under the Affordable Care Act, which has led to reductions in medical debt, enhanced health conditions, and even lower mortality rates." Blavin estimates that by 2034, approximately 11.8 million individuals could lose their health insurance because of the current legislative changes, with rural regions expected to face disproportionate impacts. In rural areas, it's anticipated that federal Medicaid spending will drop by an alarming $155 billion over the next 10 years, as found in a report by KFF, an esteemed nonprofit organization dedicated to health information. If the Rural Health Transformation Program genuinely aims to revitalize rural health services, it might fall short of its ambitious objectives. Blavin indicates that the $50 billion spread over 5 years will likely not be sufficient to offset the substantial cuts projected in Medicaid funding over the decade. Carrie Lutz, the chief executive of Holton Community Hospital in Kansas, reports a somewhat cautious optimism regarding the situation, saying, "I don't feel like the sky is falling just yet." Her small 14-bed facility is preparing for potential declines in Medicaid-insured patients and constraints on provider taxes, which serve as a lifeline for many states seeking additional federal Medicaid funding. Although the reduction in these necessary taxes has been postponed until fiscal year 2028, Lutz urges her state officials to apply for part of the rural funding, which is expected to become available more promptly. She adds, "Every little bit helps when you're already operating with a deficit." The allocation of the $50 billion program will be dispersed over a 5-year time frame. Critics point out that the distribution process may not be strictly limited to improving healthcare in rural areas alone. The proposal stipulates that half of the funding will be divided among states that successfully apply for and receive approval from the Centers for Medicare and Medicaid Services. This aspect has raised concerns over equity, as smaller states may end up receiving similar funds as larger ones. As stated in the law, each participating state must submit a comprehensive rural health transformation plan by the end of the year. The legislation specifies that states are encouraged to utilize the funds for improving access to care, enhancing health outcomes, creating economic opportunities for healthcare workers, and prioritizing emerging technologies. Under the oversight of Mehmet Ounce, a Trump appointee to lead Medicare and Medicaid, the second half of the funds, $25 billion, will be allocated based on criteria that consider each state's rural population and specific needs. The law outlines that funding could support advancements in areas like robotics, cybersecurity enhancements, and helping rural areas optimize their healthcare delivery systems. Yet, representatives from the Centers for Medicare and Medicaid Services, CMS, have not responded to specific inquiries regarding the implementation of these plans. Kyle Zebley, Senior Vice President of Public Policy at the American Telemedicine Association, points out that there exists a significant level of discretion afforded to both the White House and the Medicare and Medicaid administrator in the approval of state initiatives. Zebley advocates that states incorporate robust telehealth and virtual care options in their proposals to the government. On the other hand, Alexa McKinley-Abel, who leads government affairs and policy for the National Rural Health Association, expresses concern regarding the clarity of which state agencies will take charge of developing the mandated plans. She asserts numerous gaps exist in the application and implementation process. Previously, discussions had indicated that state plans would be crafted in consultation with federally supported state offices of rural health. However, those offices are currently facing potential elimination in the upcoming federal budget, pending congressional approval in the fall. McKinley-Abel argues for the inclusion of these offices in the planning process, as they understand the rural healthcare landscape best. Homan, representing the Rural Health Clinic Association, shares her worries about whether her members will actually see any of this funding. She notes that around 27% of the patients receiving care at rural health clinics are enrolled in Medicaid. There's simply confusion about who will end up receiving this money in the long run, Homan states. What will it actually be used for? What are your thoughts on this substantial rural health funding? Will it be a transformative step forward, or is it merely a politically motivated maneuver that ultimately falls short? Your opinions are valuable, so feel free to share in the comments.